helping them decide what kind of path they want to take, whether it's a kind of social science like medical sociology or medical anthropology or public health or biomedicine or DO or whatever. So we work a lot of with those students, and I also run the Medicine Society minor at Virginia Tech. So I have for a number of years taught students in medical school, but also students headed toward medical school. So that's just a little bit more about me.
Thank you. So Sarah thought that what you all might be interested in is how applying an Appalachian cultural competency lens would benefit patients and family systems in the region, how to encourage medical students to seek and understand the culture of the region. And then because Rebecca and I have co-taught, I knew that there's this critique of cultural competency that Rebecca's written on and published on actually, that is proposes instead cultural competency, that you, rather than focusing on the behaviors of individuals as representatives of groups, to step back more and understand the geography, the history, the economics, the power. And as I mentioned before, in our conversations about how to tag team today, I realized that I'm really not willing to throw the baby out with the bathwater on Appalachian cultural competency. And Rebecca, I think, had already been finding some faults with structural competency, even though she had advanced it as an advancement over cultural competency. And so today we're going to try out this new idea for you. If it seems like it's getting too historiographical here, sorry, we're not going to get too far into the weeds, but I do think that if you can bear with us on what does cultural competency offer, what does structural competency offer, and why do we recommend contextualized recognition instead? You don't have to actually know the cultural competency and the structural competency. That's part of the beauty of contextualized recognition, is we think that it's actually less exacting of practitioners and more flexible, and puts the onus less on providers to know everything about everyone in the entire world before they walk through your door. So we'll explain more, but I didn't want to, again, I'm not willing to throw the baby out with the bathwater, and I didn't want to dismiss Sarah's initial request. So we definitely want to also offer some Appalachian cultural competency. But first, Rebecca's going to talk about this chart that some of you have been involved with, this health science system curriculum. I think Sarah initially thought that we fall under today population, public, and social determinants of health. I think I might argue that we fall more under change agency management and advocacy. But Rebecca's going to talk a little bit more about how she actually doesn't think we fall under any of those categories.
Well, it's not that I don't think we don't fall under any of those categories. I think that we fall under all of them. And this is, Emily and I have had a challenge in our class because we've actually asked our students to model how to think about, like, comprehensively about societal health or public health or healthcare. And they've really struggled, as have we, to try to come up with a model. And, you know, in science and technology studies, which is the field that I'm in now, we firmly believe that models already orient our thinking in a certain way, which means that certain things fall in and certain things fall out, or certain things have relationships in particular ways. So when I look at this model, yeah, exactly. Correct, Natalie. So when Emily was like, which one should we do? I was like, oh, we're kind of everywhere, right? We're talking about structure and process, but also economics plays a huge role. And yes, population and social determinants of health. So just keeping in mind that you can slot us in wherever you want, but we think that we're probably touching on a lot of these points with this issue of cultural competency and structural competency. And I just want to kind of also say that I am a strong advocate of structural competency over cultural competency, which I'll talk about, and contextualized recognition, which is what Emily's kind of driving us to with these two things. Is our way of trying to bring both together. So I don't know that we'll totally do that, but everything that if you read anything I've written on the subject, you'll see that I really don't like cultural competency, and I'll tell you why. But I do think that we're trying to do lots of things that are on this chart.
Perfect, thank you. All right, so cultural competency sometimes seems like if only we understood these people, like what is going on with them, then we could help them better, or in some cases, for some providers, we could get them to comply better with what we want them to do. So let me ask you all, anybody who's able to unmute, and just sort of bounce back and forth with each other, what you think that Appalachian culture might reference. And I encourage you to do either a stereotyped version and be aware that you're kind of critiquing it even as you're saying it, or to put it out there as what you think is helpful to think of. Either way is fine, but just some stream of consciousness here.
Yeah, I'll dive in, especially talking to people I've grown up with on the West Coast who still live on the West Coast, and their perception of, Appalachia is really kind of the pejorative, uneducated white coal miner. And, I think that's obviously incorrect. And having worked in rural America, it's really interesting. My take is, once you're an hour outside of a major metropolitan area anywhere in America, you're essentially dealing with the same culture, just with slightly different geography. So I'm intrigued to hear more from your perspective about what Appalachian culture is.
Thanks, Andrew. Somebody else?
I think there's a big element of, mostly this is the outside perception, but some of it rings true of a clan culture, and an insider versus outsider. And I think that somehow it gets misconstrued as a very stuck in their ways, and difficult for an outsider to have any kind of influence.
I think for me, one of the funniest things when I first moved here, we had dinner with, I think it was internal medicine residents, and they sat for the entire session and cracked West Virginia jokes. And I, being an outsider from a completely different country, just sat there thinking, what's the difference between West Virginia and Virginia? Like, half of you are from here. To me, there was no difference. But for me, Appalachian culture, maybe remote, rural, and again, very sort of insular, without a lot of outside attempts to, they don't let people in, but they don't necessarily go out and explore a whole lot, maybe beyond where they are and they're comfortable with.
So I guess I'll be the one to start with the add to the or start with the stereotypes. So I'm thinking of J.D. Vance's book Hillbilly Elegy. My wife, who grew up as a coal miner's daughter, wanting to be a hillbilly when she grew up, only to have her mother tell her that she was in fact a hillbilly. The holler versus holler mentality of the deep Southwest Virginia and Southeast Kentucky, where you're confined by space to the point where the sun doesn't rise until 10 and sets at 3 in the afternoon.
Yeah, if you just want to raise your hands, who's read Hillbilly Elegy? A few folks, okay. Yeah, that's a whole nother workshop, but thank you for bringing up, Kelly, because it is definitely in the background for a lot of people when they think about Appalachian culture. Anybody else have anything you want to add? Sarah's adding insular, mistrusting, religious, poor, uneducated.
I'm blanking on the name of that movie with, I think it's Kevin Bacon, when they went camping.
Sorry, can you say again? Your mic is a little blurry.
I said I'm blanking on the name of that movie when there's a family that went camping and got on the wrong side of some Appalachian, I can't remember, but my husband lives in fear of that movie. So I don't remember the name.
Yeah, if there weren't a climate crisis, I would be writing a book on Appalachian set horror movies.
Deliverance, Wrong Turn.
Oh, I love the Wrong Turn series. They're so bad, just terrible. I love it. So absolutely. So horror movie, people to be feared. And we're going to touch on a lot of what you've brought up rural, white, coal, clannish, insider, outsider, insular, no outsiders. We're going to be talking about some of those, but I want to talk about them starting with Loyal Jones. Oh, actually, sorry, I forgot. Let's actually do this first, which is a lot of people don't realize how huge Appalachia is. So I'd like to show this map, which is the federal definition, and it dates to 1965. Although in 1965, it was only 373 counties. And since then, people have realized they can get federal money from being part of the Appalachian region. And we're up to 420 counties, including where Rebecca and I are right now in Montgomery County. Excuse me, it wasn't added. And Radford was added as well in 1998. And I have a hunch, and I have not been able to confirm it, that because of some Virginia Tech professors who were politicos in 1964, 1965, they refused for Montgomery County to be considered Appalachian. And you can see on this map that Roanoke County is still a cutout, like a bizarre cutout. The topography is not different, but what's different is urbanity and average income. You also see that this top tier Shenandoah mountain counties are cut out of the federal definition in Virginia. And it's one reason I don't use the federal definition when talking about Appalachian Virginia to my students, because I have students from that area. And I think that it's a pretty arbitrary cutoff. And again, it dates back to 1965 and what the politicians wanted. So this is the map that I generally use, acknowledging that Appalachia does extend farther than this. This is the map that adds back in Roanoke and Salem and Roanoke County, and then adds back in this top tier of Shenandoah Valley counties. And actually some definitions of Appalachia will add counties to the east and south of you. Patrick County, Franklin County, Bedford County, Amherst are in Appalachia in some of the definitions. And it really has to do, I think, with whether you include a county if it has part of this topography or only if the whole county, because this is really the fall line. But it's interesting because if you leave out some of these edge counties, you're actually leaving out a lot more racial diversity from more slave-heavy industries in the past. So just to say that the definition is really political, changing, arbitrary in a lot of ways. I think that a lot of people like to say they know, they don't actually say it this way, but I think the way people use it is they know Appalachian when they see it, and we apply it selectively. I myself consider Roanoke Appalachian. I don't see how you can see a city built on extraction of coal in via railroads as not Appalachian. It is absolutely integral to the Appalachian global economy. So whereas some people insist that Appalachian is rural, I insist that the urban places are Appalachian too, but a lot of the Appalachian values that we're going to be talking about do get associated more with rural communities. So we'll be focusing mostly on rural Appalachia when we say Appalachia today. Questions about either of these maps? Frustrations with them? Nobody as frustrated with them as I am. Okay, so Loyal Jones was a professor at Berea College in Kentucky, and he wrote an essay called Appalachian Values. Well, I don't believe in Appalachian values. I believe there are a lot of people from a lot of places and a lot of belief systems in Appalachia. So I've drawn on Teresa Burris from Radford and Ricky Cox, and what they've done is in conversation with Chad Berry at Berea, currently, they've rewritten it as values in Appalachia. These are some values you might find in Appalachia that might stand out against normative metro values. And back to, I think it was Andrew's point about, a certain distance outside of metro, you have potentially some commonalities that aren't specifically Appalachian. So these elements that I'm going to talk to you about. I'm only going to pick about 6 of them today. I'm not going to do the full extended thing from Loyal-Jones, but the ones that I'm going to pick, they aren't unique to Appalachia. You can find them in a lot of different cultural groups. And they are, yeah, so I think that it's important to know going in that not everyone in Appalachia will hold these values, and these values are not only found in Appalachia, and that even my naming them today risks reinforcing stereotypes. Okay, so one of them that I find useful actually to think about is Loyal-Jones says, we will go to great lengths in Appalachia to keep from offending others, even sometimes appearing to agree with them when we in fact do not. We will give the appearance of agreeing to attend all sorts of meetings that we have no intention of going to just because we want to be polite. So it's feeling impolite to say no. Obviously, this is going to be a huge problem if you're asking someone to come to a follow-up appointment or participate in some kind of parenting workshop or whatever you might be hoping that they will take advantage of outside of their interaction with you. Another one that I thought might be important to think about and that you've probably seen is familism, is what Loyal-Jones calls it. A sense of responsibility that goes way beyond what, for me, a suburban heteronormative family would have expected. I never would have told my professor I can't come to class because my third cousin's husband is sick and I need to go home and help take care of them. Or there's a funeral that I need to go to that's, several, just not, in other words, in my experience, excuses were confined to nuclear family, maybe a grandparent. But for some rural families, that sense of obligation and responsibility is much broader and is a legitimate reason to prioritize something that normatively we might not consider a priority. And sort of similarly is the love of place, which is part of the stereotypical view of Appalachia, but also I think it's important to think about how specific it is that coming from an hour away to Virginia Tech as an undergraduate can be overwhelming. It can be frowned upon by family. It can be it can seem like a much bigger distance than a lot of us who were raised in a more, if we were raised in a more suburban, mobile, upwardly mobile environment than we would imagine. I mean, my assumption was we moved all the time. Of course, you travel, you change cities for jobs. Of course, you change cities for education. That's not the case for a lot of people. And that can matter in terms of even coming to, say, Roanoke from Wise County, or if you want to suggest that someone go to Charlottesville for a specialist, that can be really, really out of bounds. And I think that this is a little bit different than saying insular, or what were the other ways people put it? I think it's important to say that media is pervasive, both mainstream media, whether that's cable news or social media. In fact, a lot of people may not have computers, but do have phones and can connect to social media. And so I don't think it's accurate to say that people aren't aware of the broader world, but their day-to-day lives are lived in a smaller geographic range often. And what we, or any rather, not we, but professionals might expect of people can go up against that. This is another one that I wonder if it comes up with any of, I don't think if this would come up with any of you, because you all seem like very lovely, approachable people, but maybe you have colleagues who don't come across as modest and inviting as you do. I don't know, maybe that's a stereotype about health practitioners that I need to get over. But if if it's a strong tenet for someone that you're not better than anybody else, but nobody else is better than you, then anyone who comes across as arrogant or pompous is going to lose trust. Anyone who's, I mean, I don't think it's normal for professionals to boast, but maybe to be interpreted as putting on airs. And maybe we don't always know what is interpreted as putting on airs, but maybe it's something that we can be alert to. And part of the way to combat any sense that we might be putting on airs is by laughing at ourselves. And that's valued, being very self-deprecating. Loyal Jones says, I was hiding behind the door when the looks were passed out, as an example. But there's very little respect for people who can't, who take themselves too seriously, for some. Individualism, self-reliance, and pride, not wanting to be beholden, wanting to do it ourselves, or at least in a small set of people who have a mutuality, who they'll be there for you and you'll be there for them, but it's not a handout. In those kind of personal networks, aid can be acceptable, but perhaps for some people, aid outside those networks is embarrassing, or could put someone in a place to think that they're better than you, which would go against the non-hierarchical. And let me say something about hierarchy, though. It's not that people don't have positions. People do have different roles, and there is deference to those roles. So I'm not saying that if you went to a meeting of people in, say, rural Giles County, there wouldn't be a pecking order. It's complicated to say both that no one's better than you and you're not better than anyone, and also to say that there are roles that people have that communities acknowledge, and it's important to be aware of what those roles are in certain circumstances. This, I think, leads to a sense of privacy, like not airing your dirty laundry, especially if you were talking about behavioral health issues. This could really come into play, I believe. So what are some ways to negotiate these values according to the cultural competency model? Well, one thing is warm up chat. If you only have 15 minutes to spend with a patient, how are you going to spend 15 minutes socializing? Some of these are not going to be easily adaptable to that environment. But I think it's helpful to know that the people, if you have someone you're speaking to who has an accent that you consider a strong mountain accent, they may be thinking in their head, as soon as I open my mouth, this person's going to assume I'm dumb. Because they've had that reaction before. The full quote from this particular person in West Virginia is, your IQ drops 30 points the moment you open your mouth. And you can see it in the person's face. As far as the insularity and the small geographic scope, there can be additional ways for people to place you. You don't have to be from Lee County to find a connection to it. And if people can place you, then that can be a huge aid. What do you have in common? Because you are probably not as different as it might first appear. How do you fit into the world? Maybe you have a common acquaintance or a common, maybe you can talk about the Bristol racetrack, right? Like something that helps place you in their world, and place them in your world as well. So one other thing that I found really helpful is Anita Puckett's work. She was the director of Appalachian Studies before me here at Virginia Tech, that direct requests can be rude, orders can be rude. And so a lot of times there's a sly way of suggesting what you want someone to do without telling them to do it. Here, this plays out a lot between VT professors and admin who live in rural parts of Montgomery County or Giles County, where I might ask someone to do something and her response might be, did you think about doing X, or maybe could you do Y? And what she's saying is, I don't want to refuse what you asked me to do, but I do want to tell you that you should actually take this step before I do that, or I'm not allowed to take that step, but I'm not going to say no to you, and I'm not going to tell you to do it differently, but I'm going to sort of get around it some way to suggest that it should really happen this other way. One of the things about that is that sometimes people can address problem solving through storytelling. And I loved this in Dope Sick, if you all have seen the television series, that when the small town doctor speaks to the dad about his daughter who is queer, he doesn't address it head on. He says, I once had a cousin who, and then he tells a story about that. So I think, again, in a 15-minute window, is that something that a tactic you're going to be able to adopt? Maybe not, but maybe you can recognize if someone's telling you a story as a way of trying to get you to see it differently than you otherwise would, and a way of maybe telling you no without telling you no, or a way of suggesting an alternative path. So we want to stop here, and if you're comfortable, unmute and just trade some reactions to the cultural competency model. Is it useful? What's it demand of you that seems unreasonable? What's missing?
Just to contextualize Emily's question, what she has just offered you is a cultural competency take on Appalachia. So we want your responses and reactions to that hot take.
So for me, this is Kelly Whitmer. I trained in the rural primary care track at East Tennessee State for medical school, and we
Did
had
you train with Robin Fire Robin by chance?
I don't
No.
recall.
Okay, I'm not sure when he retired.
Yeah, my take on the cultural competency model, as you've presented it, is that it parallels the training that we had in our communications course for how to interact with patients, which was across the medical school, not just for the rural primary care tract students. In that, the aspects that you've highlighted from the values in Appalachia and Appalachian culture, and the examples that you used were specific to how to communicate with patients and how patients may respond to communications that they receive from us. And although it wasn't couched in those terms, in the terms that you're using 22 years ago when I was in my first year of medical school, I found it very useful for helping me to interact with patients. And it wasn't, I mean, it's now been 20 years later, and I'm now married to an Appalachian, and so I have a different perspective than I once did, but I did find it very useful for guiding my interactions with patients and helping a city slicker like me, who grew up in a town that has the same population as the Commonwealth of Virginia, to interact with folks from Appalachia. And however, I have an acting background, and I felt like it was helpful in allowing me to affect and to develop an affectation that I could put on in order to interact with patients, rather than the genuine understanding that I feel like I now have of Appalachian culture, which includes a whole lot more of the structural aspects that I'm sure Dr. Hester is going to present on later.
Other reactions? You're unmuted. You want to jump in?
Yeah, I think one of the limitations, as Emily indicated, was that groups of people aren't homogenous, so it's real hard to draw generalities. But I hear what she's saying about Appalachia. People don't realize this when they first meet me, but I grew up in Appalachia. I grew up in East Tennessee. most of my life was spent with friends who were, more rural Appalachians. So, it hasn't ever been difficult for me to speak to and to understand folks from this region. But I think it's probably helpful. It might be helpful in the future for me to let people know, that I do have that connection, although because it's not obvious. I mean, it's never, well, it's hardly ever obvious unless, you speak with the accent. And it's clear that you're from that region, but, for me, it's not. But that hasn't ever been a really big barrier for me, because when patients are coming to see me, they're here for my surgical expertise. So they don't always expect me to relate to them as a community member.
Thanks.
I think
Yeah,
that
Jacqueline.
I
Oh,
think
sorry,
that,
Biddy.
Presenting it, and I know I agree with a lot of the examples that you did from working there. What struck me is that some of the things would be what I would say for people from a lot of my more indigenous Mexican population, Salvadorian, I would say it's almost small town values that translates to lots of different areas in the world. It's just in this case, we're talking about Appalachia, but I think a lot of the things that their interaction and how they relate to you would apply to lots of different populations in the world, but a much more global perspective.
Absolutely. Jacqueline.
So I have less experience with this, but from being in New York and doing residency in a really cultural diverse patient population, and something that you guys were mentioning earlier about having, and not necessarily an issue with cultural competency. I think that the cultural competency model that you put up here is a little different, and in the framework that I'm used to, in that I think, the way I see it is more how to tailor individualized care. And in me trying to gain a cultural awareness of how that may influence the care, the access to care, or the perception of how you receive care. And I know for me in the past, and again, not related specifically to the Appalachian population, but in New York, I would have certain patient populations that from a gynecology standpoint, would refuse different type of exams depending on what type of provider, or just from a cultural awareness, they really truly did not believe in exposure of certain body parts during the office visit, and in trying to talk with them about what makes them feel comfortable and how we can still get the same equity and level of care and be more sensitive to their cultural values, which I know I agree with what A said. It's hard because what you presented, I think, is when people take a patient population and then they universalize everything that they've heard and apply it to every person. And I think more of cultural competency as trying to provide individualized care. Does that make sense?
Yeah, thank you so much for those reflections. I see Andrew's unmuted, but I'm going to turn things over to Rebecca and keep moving, because I've taken up more time than I wanted with this piece of the big puzzle.
Emily, were we going to do a break, or are we just going to trickle through?
I was thinking that since we didn't start at 10:15, we would just power through, if that's okay with everybody.
Yeah. And do you want me to advance the slides, or will you?
Which do you prefer?
I could just tell you to go to the next.
Yeah, let's do that.
Okay, so as I said, I really do not like the cultural competency model, and I don't like it for a lot of the things that you all just identified. It becomes too homogenizing. It also focuses on individual behavior to the detriment of understanding how those behaviors are actually structured and shaped. And so there's a lot that has been written by physicians, particularly on the East and West Coast out of New York and UC San Francisco, UC Berkeley, and then Jonathan Metzl, who's over at Vanderbilt, around structural competency, that is basically trying to get us to move back a step and say, how is it not just, how do we focus on behavioral health? What are people doing? What are the decisions they're making? What kind of cognitive processes are going on? But how do the structures around them actually shape those behaviors and cognitive processes, right? So social determinants of health has tried to really focus on this, the idea that there are upstream factors that in many ways kind of guide people's behaviors, right? So we could sit there and tell them all day to eat right, but if they live in a food desert, as we know, it's much harder, for example. So structural competency asks us to look at the structures and systems in play and to kind of pay attention to the ways that they shape behavior. Cultural competency focuses more on the behaviors of either individuals or particular groups. One other beef I have with cultural competency is it means everything and therefore it means nothing. So we use culture as a proxy for lots of things. Just identifying some of the pieces that we talked about that were brought up earlier. It means religion, it means poverty, it means geography, people are insular, it means clanism. I mean, it starts to take on, it means language and speech. So at a certain point, it means race. We most often use it for race or ethnicity. So culture stands in for so many things that it loses its analytical clarity. So the effect on learners, medical learners, is that they get frustrated, not only because it's seen to be a soft science, but because it's too many things. And they're like, look, how am I supposed to know about everybody's culture? Because culture is like food and dress and talk. But also the research is pretty shady or sketchy on the actual impacts on equity and health outcomes after people are exposed to cultural competency. So Emily and I come at this from different ways because without cultural competency around Appalachia, the question of who Appalachians are and what it means to live in Appalachia or have multiple generations kind of gets invisibilized. But at the same time, I'm not a big fan of cultural competency because I think it homogenizes and actually is not analytically precise. So I want to take us upstream. Emily, if you'll go to the next one. And kind of juxtapose a cultural competency framework to a structural competency framework. So on the one side, what you get, and this is what I've written about, is that I not only don't like the concept of culture, but I also don't like the concept of competence, because when I do workshops with practitioners, I ask them about their cultures and they stumble and they're like, I don't know. I mean, we eat this, but I also live here, but I've moved here and I speak these languages, but I'm not quite. So they can't quite be competent about their culture. So the idea, I think, that we ask anybody to be competent about someone else's culture or that someone should be competent about our culture as if that were one thing, I think is quite arrogant. So I don't like culture and I don't like competence. And as I said, it tends to focus on the individual client and their behavior and their difference rather than the kind of commonalities that we share with them in many ways. So a kind of structural competency framework can say, look, actually we share some things in common like geography or class or whatever. When I first got my PhD, I was working at a medical school. I was making good money, but I was just out of, getting my PhD. I made $80,000 a year, but it wasn't going all into my pocket. It was going into mortgages and childcare. I couldn't afford strep throat medication for my kids. And so even though I'm like, have a PhD and class wise, I'm different than my patient or like people I interact with, actually, we're both sharing something around our inability to, afford medicine in this healthcare system, for example. So I think that when we start to focus on behaviors and individuals, we lose the kind of structural similarities, but also the forces. We already talked about the homogenization. And then the piece for me as a political scientist is the decontextualization. So we have no sense of history or power, even the power structures that practitioners are embedded in, right, within their institutions, the limitations that they have, the kind of constraints on their own behavior. Emily mentioned multiple times the 15-minute clinical visit. I don't know how long you guys have, what, the institutions you're in. But that also, I imagine, shapes your behavior, shapes the ways that you hear narratives because you just want to get to the chief complaint or whatever. So by contrast, the structural competency framework will focus on the power dynamics shaping interactions, even the ones that seem like they're between two individuals. The economic forces of the healthcare market, the political forces of this country shaping people's perceptions of vaccination or treatment, gender relations, right? People's understanding of who can look at their private parts or not. All of these things come to bear, even though it just seems like it's a kind of individual interaction. I think a structural competency framework helps us acknowledge and pay attention to those power relations, which we already know are there implicitly or explicitly. It helps us, as I said, reflect on our own social and economic location and our own assumptions, our own epistemic and kind of normative assumptions about what is normal behavior. A behavioral health model dictates what is normal behavior, but when you start to kind of expand your idea of what is normal or what it means to be human in multiple ways, all of a sudden, you know, some of those kind of like guiding behavioral health promotion kind of lenses can kind of peel off, and you actually can have a real kind of more candid interaction with another person. And then it gets to the roots of the inequities, right? So rather than looking at, you know, who's drowning right in front of you, you go upstream and you try to figure out who's throwing the people in the river in the first place, right? So you kind of get to this idea, which then shapes the kinds of interventions that you're having, right? So there's a guy, Rishi Manchada started this movement called Upstream Doctors, and he had a patient that kept coming in for asthma, kept, you know, like prescribing her albuterol, inhaler, da, da, da. Eventually, he started asking her questions about, you know, her living situation. What's going on? Where does she live? What are the conditions? Found out that there were lots of triggers for asthma. So he wrote her a prescription for a tenants' rights organization rather than continuing to prescribe her an inhaler. So it sets up different interventions. It sets up different kinds of relationships with patients. So I think a structural competency approach is really helpful for that. And it helps you be, I think, more empathetic. There is no solid research that shows that cultural competency actually makes practitioners or anyone more empathetic to their patients. Even, you know, this idea of cultural humility, I've kind of critiqued it because I'm like, it doesn't tell you what you should be humble about. If we all look in our heart of hearts, we're not racist, we're not discriminatory. Nobody would be like, yes, I am, you know, this or that bad thing. And so cultural humility approach, I think, doesn't help us get the kind of tools we need to really contextualize who our patients are, what they're dealing with, but also what we're dealing with, what we're up against in the kind of healthcare market and society that we're in. I think structural competency can help us with that. Okay, next, Emily, thanks. So the way I kind of think about this is that cultural competency is important because it can help us with some first order observations, right? What am I seeing in my patients? What are they doing? But structural competency gets us at a kind of second order observation to then contextualize those behaviors, not just stay at the level of judging and assessing what the patients are doing, but to kind of put them into context and understand how those practices are shaped and how our own practices are shaped, right? Clinical biomedicine has lots of their own cultures, if you will, their own particular languages, their own uniforms, their own, you know, ways of interacting, their ways of handing off a patient, right? There's specific narratives that people have to follow, ways of assessing patients. These are all very culturally inflected. So when we start to take a structural competency approach, we can also start to see how our own views and behaviors have been shaped by the kinds of institutions and policies that guide our lives and our interactions. Next. Thanks. Okay, so in broad brushstrokes, what does a cultural competency framework offer? It sort of, so if you were going to go into an environment where you're teaching medical learners, right? I understand that many of you work with third-year students. So teaches them to recognize structures, right? The role of structures in society, the ways that, we might say, well, I'm not individually discriminatory or racist, but to understand how systems are set up or structures are set up to reinforce particular racial inequities. And so we start then from that premise, as opposed to the idea of, ourself or a patient, are they racist? Am I racist, right? That's a very different way of talking about things. The second is that it rearticulates the idea of cultural formations, which, as I've said, I think are not analytically distinct enough or clear enough in structural terms. So how is it that these cultural formations that we talked about earlier, such as speech patterns, geographies, clothing, food, other kinds of things, are actually kind of structurally determined in a certain way, or structurally shaped. The third is that it offers language to talk about structure. So rather than trying to teach people how, X, Y, or Z population thinks or acts, we start talking about, what are the structures that they're up against, or how is it that food deserts or poverty shapes people's food choices. That's a very different thing than talking about people who make bad dietary choices, diabetics who, eat the wrong food. Those are different ways of having conversations. A fourth aspect of structural competency is that it helps learners observe and imagine structural interventions. So just like I mentioned with the asthma case, where the structural intervention would help the whole building that this woman with asthma was living in, because the tenants' rights organization would come in and be like, look, landlord, you have to clean up your building. So everybody benefits, rather than that more targeted individual, like each person gets their prescription for their inhaler and goes off, and then the next person comes in. So to start imagining different ways of intervening in health issues. And then finally, to develop a kind of structural humility. So the idea is, one of the things that Emily and I do in our class in societal health is we ask our students, which healthcare system they think is the best. And of course, they're going to be like, oh, the United States, we're the most technologically advanced, and we this and that. But then we start to drill down into the data, and we show them that health outcomes, morbidity, mortality rates, we compare to places like Cuba, which is highly stigmatized for being communist. But then we look at different health outcomes, or somewhere in Central America, right, which we wouldn't expect to have such strong healthcare systems or such robust health outcomes. And in fact, they do. And so it helps develop a kind of structural humility around, that we're not just superior, that, I heard a lot from my students when I used to teach in Texas, that, they would basically rely on their own knowledge over the lay knowledge or expertise of their patients, because quote unquote, we know more. And I would challenge them and say, yeah, you know more about what? You know more from the discipline that you're in, but sometimes the patients that you are interacting with actually have different kinds of wisdom and knowledge that we can learn from. So a little bit more structural humility about where people are coming from, systemically or structurally. Next. Sorry.
No, I was just thinking that it might be time.
Do we have, I can't see what's
See if
next.
there.
Okay.
Well,
yeah,
next
okay.
would be contextualized recognition.
Okay.
So maybe actually talk about that, and then we'll pause and have
Yeah.
questions or reactions.
So Emily and I were chatting on my back deck about 2 weeks ago, and we were talking about kind of, she doesn't want to throw out cultural competency. I have written strongly against it. Like I said, I just finished a book about it. I really have written why I think it's just not helpful. But on the other hand, there are good political reasons. It's the language, it's the lingua franca, people understand it. It brings visibility to populations that wouldn't otherwise be kind of brought out and kind of put into sharp relief if we didn't have this kind of language. And it offers some tips for interacting in ways that, new learners or people who are new to an area might actually find useful, at least initially, before they kind of get their feet in the ground. So Emily really wanted to hold on to cultural competency. I really think that structural competency coming out of medical, it's mostly medical practitioners who are trained like me as social scientists. They're usually MD PhDs, are kind of pushing for this lens. And so how do we marry this? We came up with this term, contextualized recognition, right? Where you understand people kind of in these more cultural competency ways. What are some of their life ways, behaviors, decision-making processes at this more first order level, but also try to put them in a broader context and put yourself in a broader context. What kind of predispositions are you bringing in? What kind of forces are impinging on your own interactions with your patients? And so that's kind of what we came up with. So it requires attention to the structures, the geographies, and the knowledge systems that shape behavior and health outcomes, while at the same time trying to account for, this idea of the more kind of tailored, individualized care. Who is the person sitting in front of you? How do you orient them in the region or in the, cultures or identities that they have? So this kind of interactive structural and in maybe individual dynamism is kind of what we're calling contextualized recognition. So I'll stop there, and I'd like to hear your feedback on that. Don't make me call on you, because I will.
I think it's a wonderful blend of both. It's probably a new coin of a term, but it's probably what we've all been doing in some way or form. You know, we all talk about social determinants of health. Well, that talks about upstream and downstream effects. But I think the cultural competency gives, I think you're correct, it gives you a point of reference to deal with this population, as long as you understand that you're never going to have mastery. And that's not something you should be trying. Like, I know all about the Hispanic population. Like, no, you don't. And so cultural humility and just a good framework to approach a specific population. And I think it comes back to there being a lot of overlap with different populations. So we're talking about Appalachian, but it's about poverty, and it's about lack of access and transportation and how you view the outside world. So a lot of that just relates to tons of other people around the world that we interact with. So.
Yeah, that's super helpful, Vidya. That I forgot who said it, but you know, they said whenever you get into kind of rural communities outside of a metropolitan area within an hour away, they're all similar, right? Because structurally they are all similar. Even if the faces look diverse, there are lots of similarities because structurally they are similar. Mm-hmm.
I think kind of parceling out the terms and definitions is probably a little bit more challenging for me personally, but I think the underlining principles of the blend of the two is really appealing. And I think whenever you mentioned I think it's such a perfect example is the asthma example that you used and when I think back to that, I think, you know, when I teach the course with the students, I talk to them about, you know, I hate the term the non-compliant patient. I really think that we should do away with that, because there's a diagnosis code for that. And we tell patients, you know, you sign out AMA and your insurance won't cover your stay here. And I think I've called actually like risk management several times, and they're changing that jargon, not because of me, but it was in the pipeline anyway. But I think part of that is, it's not that the patient doesn't want to receive care. It's that the structures that we have in place have not allowed them to do so. I think, you know, when I think about our own clinics, you know, with COVID, we've said, you can't bring your children to the visits. And then we're trying to figure out, well, why has COVID impacted our Medicaid offices more than some of our private offices? Well, we just put up more and more barriers for these patients. And then we've dismissed them from our practice. And what's happening is we're seeing patients with these huge gaps in care, because when we turn them away at the front door for not having their children, the perception that they're getting is that we don't want to take care of them in their current, you know, cultural, like so I love the idea of like contextual recognition, because it really speaks to the fact that, you know, it's not a simple solution for a patient population. It's really a focus on what we can do to change some of these barriers.
So this is brilliant, Jacqueline, especially because this is a way that you start to help your learners see structures, right? Because these are examples of you seeing structures and these policies that are setting up inequitable outcomes. And they are contextual. If we didn't have COVID, then different things might be afoot, but we have COVID. And so the policies and practices that we have in this particular context, at this historic moment, are setting up particular kinds of inequities. So helping learners at the same time recognize, good to see you, Cynthia, at the same time recognize and see the structures and then imagine alternatives, right? Whether they're internal to the organization, where you're like, hey, you know, I went to risk management and tried to get them to rewrite the policy, or little tricky things you do by, writing a different code for something, or, whatever you can do to kind of play the game to be able to, trick the policies or trick the structures or modify them, I think is important to help learners understand how to do that so that you do push for equitable and successful health outcomes.
Dr. Hester, I just had a quick comment. I'd really
Yeah.
like to talk. Coming from a really different culture, I think your assessment that we cannot completely understand all the difference is totally true, because even from where I come from, depending on your religion, your socioeconomic background, the cultural practices, how much you earn, it is so different. And I just 2 weeks back did a noon conference for our residents on the same topic. And the bottom line is, it is so hard, even, I've been here so many years, to understand different cultures and what people think, how they behave. It has so many different variables that you really have to individualize. You have to understand the patient, get their reaction, and try to understand how you fit into that and how you can help them. So really trying to understand, what the patient needs and what they're thinking, how they will behave, what their, social standing is, what can they afford, is really important. And I think on that, in the primary care, we get here 30 minutes for a visit. So I tell my students and residents, we need to know the patient. You need to have them come back, especially in primary care. And, trying to understand what they understood, what they took back, and how you're impacting their care. So I think I really like that. Thank you.
Thank you. Yeah, I get pushback sometimes from medical practitioners that this is not their domain, that trying to understand systems and structures is something that, they can hire in a social worker to do, or, they work in teams for, but that really it's just demanding too much, especially when they're, in the first couple of years of medical school. They're like, I'm just trying to get a handle on the science and trying to do it right and not screw it all up. And, I'm dealing with imposter syndrome, wearing this white coat. And now you're telling me that I have to, on top of it, I have to try to learn about systems and structures and how they all play a role. And so it's something that I think, the culture of medicine and academic medicine is grappling with and has to grapple with. How best to convey this kind of, this dynamism between understanding and attending to structures and seeing the patient in front of you without reinforcing stereotypes, but also recognizing that there may be some commonalities. It's a big ask. I understand it's a totally big ask. But I appreciate you saying, that this ask is worth doing because I do think that it will lead us to better health outcomes. The model that we've had for 2 decades isn't necessarily, it hasn't been successful. And there's actually a fairly robust body of research that says that it reinforces racism and discrimination because it reentrenches stereotypes. And people, when they have short amount of time, can only really, refer to what they have in their mind. And I'll give you an example of that. I know we're kind of running short on time, but I did I used to teach this ethics, like small practicum at University of Texas Medical Branch. And I had a case study of a diabetic woman. She had diabetic neuropathy, came in, did a little case study about her. She mostly didn't eat meat. She was pretty poor. She gave all the meat to her husband that she bought at the dollar store, had a garden, ate out of her garden mostly, like, this typical kind of little scenario. And this white male student, the first thing I said, when I said, well, how would you like interact with this patient? What would you advise her? The first thing he said was, I would tell her to stop eating all that fried chicken. And I wish I were making that up, but I'm not. And so the woman was a vegetarian. She didn't eat meat. Just because she was Black, something got triggered in his mind. And, in a quick moment, because of the society that we live in structurally, those stereotypes become guiding principles, right? We think about practicing race medicine. So yeah, I think that, we do need to start helping students recognize how those structures operate, not just in society on their patients, but also on themselves, and not hold them to be experts in everybody's culture.
Just one more quick thing. What I also like about this aspect is that sometimes I think cultural competency, people view it as a narrowed lens of diversity, inclusion, and equity to be primarily focused on race. And while I think that's so important, sometimes I think other marginalized populations, it does a disservice to them because people tend to forget about them. You know, you talk about people that have been incarcerated or patients that are morbidly obese that have stereotypes projected onto them from the healthcare system. Or, you know, I know, you know, but people with disability, I think is a larger scope too. And I think this gives a framework to be able to focus on a broader range if you don't confine it just to culture.
So Andrew, it looks like you want to say something, and then we wanted to get to your case studies. I think we only have 10 minutes, but did you want to jump in and say something? And then
Yeah, no, I think this is a really beautiful blend of helping us understand the patients we're interacting with. And I love that that you've taught this to medical students in the past. And it's very important for the longevity of medical students' careers as physicians to understand that the primary role of our job is communication and effective communication. You can't do that unless you understand who you're communicating with. And I'll often talk to my residents about how we have to incorporate code switching on shift very frequently in the emergency department, especially an emergency department like the one here in Roanoke. You can be taking care of a highly educated, very affluent lawyer, and then you're popping in to take care of a transfer patient from a hauler in West Virginia, and then you're taking care of a psychiatry patient who just got off the bus after somebody from a large city bought him a bus ticket to Roanoke. And so you need to be able to effectively communicate using your medical knowledge, but the language that these different patient populations can understand, in a very rapid sequence. And then when we sit down and we get on the phone to talk to our colleagues, we then switch into the language of medicine, which is, you're having all of these different conversations. And so putting into understanding the structures that have put all these people to where they are and where they're coming from the background just makes that job easier. And appreciating that, I think, at the medical student level will help with the massive burnout that we face in our field. So I love this. I thought this was an excellent presentation.
Good, that's good. Yeah, I used to work with medical students that did community. They had a community clinic, like a student-led clinic. And unless they were given some training on the structures at work that would shape homelessness or migration or drug addiction or any of those factors, it just reinforced their stereotypes about homeless people or migrants or drug addicts or whatever the term that they had, because they just didn't have enough tools to really understand why it is that people were in the life they were living or the identity they had. So I think it's helpful for burnout and for treatment. Okay, so thanks you.
Vidya, you're unmuted. Is there something you wanted to add?
I think all I was going to say is that I think it forms the next step. Like, what do you do once you recognize that the structures at play, it forms the basis for your advocacy, or how do you address the problem?
Yes.
I'm happy to jump to a case study.
Well, I just want to say I love, forget which of you said this, but I love the thought that perhaps this is what you're already doing anyway. And we're just trying to come up with this like newly coined term as if it's a new concept, but it's already, you've been using different tools in your toolkit, the behavioral ones, the cultural competency ones, the structural ones, what is this person up against in terms of transportation or budget or what have you, and that you're already doing what we're presenting as this novel thing. But maybe we're helping articulate, together, all of us today are helping articulate what it is that's valuable about the way you're practicing. And I don't know if it's useful. I mean, we have only 8 minutes. We obviously won't have time to do all the wonderful scenarios you all submitted. Thank you for taking the time to do that. But does it seem like a potentially useful use of our last few minutes to look at one of them at least, and sort of put on our cultural competency hat, and then our structural competency hat, and then our contextualized recognition, and see what they each offer? Okay.
Yeah, I think so.
I see some nodding. We were going to come back to this, but I think we're going to, Natalie made a good observation about this. And so we're going to let that stand in the chat. And Oh, okay. We'll share this with you. Rebecca is going to give this, but we may not have time right now. Do you want to give a really quick gloss so that we can do a case
This
study?
is just a different model that's messier and trying to, map some of the things that some of the pathways. What I really like about this that Nancy Krieger did, she's public health out of Harvard, is talk about exposure, susceptibility, and resistance up in the left-hand corner. And we can think about exposure on a social, political, or economic level, right? If we think about media exposure and vaccination at the moment, right? And all the politics of that, but we could also think about it on the individual level, or we could also think about it at the level of, an organ system or, chronic systemic inflammation or whatever. So you can bring it down or take it out, and you can talk about susceptibility and resistance at all those levels, right? You can talk about immunity and resistance, but you could also talk about social resistance. So I think this is an important model for kind of thinking and teaching around these different levels. It's different than the one that you all have. Not that it's perfect, but I think it's interesting and important and useful as well.
All right, this is the prompt that you responded to. Thank you again for that. I had one of my partner's patients come in. She had high blood pressure and I recommended treatment. She was extremely unhappy, became angry, and left the room. If you started with a cultural competency model, I don't know what you would have to go on, because this is all we know about this scenario. But do you think it's possible that cultural competency would have anything to offer? Maybe not, again, especially since we don't know how the provider read or misread culture in that scenario. Structural competency.
Yes, family eating nutrition, access to nutrition dense foods, and exercise, green spaces, and looking.
Yeah, is there access to nutritious foods? Is there access to safe place to exercise or time to exercise? These are some of the structural kinds of questions that might come up.
In terms of structure that we hadn't really discussed, though, that I think might be applicable here, is that traditionally medicine has been a field where you, especially in primary care, you get to know someone and you see that same person over and over, and you develop trust in a relationship. And so perhaps it was the introduction of a new healthcare provider here that disrupted that trust. And not only did it disrupt that trust, but that new person then said that there's a problem with the patient that needs to be addressed. So just something else to consider.
Yeah, so the patient might be surprised both by having a different practitioner, maybe by the way that the suggestions were communicated. I was, when Rebecca and I were talking about this example, I was talking about being a grad student at Emory University and going in, and I had a physician's assistant because it was a quick turnaround. I couldn't move my neck. Everything had frozen up and I didn't have time to wait for my regular MD. And he said, well, physical therapies starting tomorrow, twice a week for however many weeks. And I was furious. I was furious. Maybe I was already off kilter because it was a new provider that we didn't have a relationship, but mostly I was just like, you're asking for something that my health insurance doesn't cover. And that would the biggest problem is that it would take time. And what I need for you to do is to give me a prescription that will release this tension and make it possible for me to teach tomorrow and to write my dissertation and whatever. And I actually said this to him. I was like, this is a really tough situation you're in. You're trying to address long-term behavioral health issues in this 15 minutes that we have. And I just want some drugs. And I recognize that neither of us is in a good place right now, but I'm really frustrated. Justin, did you want to chime in?
No, I think in addition, and I think there was part of that spoke to this a little bit about the patient's chief complaint is not always matching what our goals are. And now maybe the patient came in for high blood pressure, but projective identification, they may be upset about something else, and we're looking for something, but it may be in the patient's set of worries that their blood pressure was not the area of focus, and they felt like that was taken away from them. So it may have been a permission issue.
Maybe, or maybe not the thing that they had the resources, emotional or time-wise, to deal with, or budgetary or otherwise. And one of the things that Rebecca and I talked about when we talked about this scenario is how bad it must feel for the provider to have that encounter. And that what we hope that the structural competency and the contextualized recognition does is do the kinds of things that you all are thinking about: the disruption, the newness of a new provider, the way that scheduling works. That
Emily froze. That basically you don't end up blaming yourself in the end. You understand
comes in that moment, and that we hope that contextualized recognition lets us be more forgiving of ourselves in that moment.
I don't know if we have a time for another one. Are we out of time? It's 11:59.
We can do a couple more minutes. We'll give you a couple more minutes.
These are both anti-vax narratives. So it might be useful to see if you think any differently about them after our conversation today, having the space and time to reflect on what some of these dynamics are.
And really, do you think that cultural competency and or structural competency would help in either of these cases, or both?
I think this scenario is best addressed by Dr. Morrow's commentary on narcissism, to be perfectly honest. I think you guys were on that before kind of we jumped in. But I see this every day in the emergency department, people who refused vaccines, and as soon as they get sick, they want everything done to make them feel better. And it just strikes me as inherently selfish, greedy, and narcissistic. And I explained the science behind the monoclonal antibody infusions that they all so badly want to feel better, and how it's really just a vaccine that was given to mice after we hybridized human stem cells into those mice DNA, and then harvested them, killed the mice, and it cost $20,000 instead of the free vaccine. And the first thing they tell me is, that's great, I still want it. And so it really, I don't think there's any getting past this. I think that this is a inherent structure or a societal flaw in a way that our society is moving towards a individualization as opposed to a collective society.
Sarah, do you have a different thought?
No, Andrew and I probably shared the same views on this. When I wrote my prompt, it was COVID related. It was about patients not believing that they have COVID and refusing all treatment for COVID and refusing to make decisions regarding life and death for their loved ones with COVID. And I think from maybe like a cultural or structural perspective, politics have influenced patients and people's decisions regarding their healthcare. And that might be the reasons why they're making these decisions, whether or not we agree with that. But there's really no reasoning, I have found, especially as a palliative care doctor and trying to have goals of care conversations with patients who are dying or who will not survive, and being unable to relate or communicate or effectively approach these discussions.
Lydia, and then A. Oh, and sorry, Jacqueline, I didn't see you were in the video.
It's not specific to this case, but it's somewhat similar. Last year, we were having a lot of issues with the patients in the ED or other places getting diagnosed but not quarantining and hence spreading it. And this is at the beginning of the pandemic with COVID. And they really had to go back and look at why are they not quarantining? Did they not understand? And this wasn't a specific population. Was it a language barrier? that was one thing we could address, or was it really beyond that and structural and cultural understanding how they live in these multi-generational families, many people in the homes, and so it was not easy to quarantine. Were they the only person that had a job to support all these people? So just saying go home and quarantine for 10, at that time it was longer, 14 days, was an easy thing for us, the medical professional, but we did not understand what was happening. And then we would get upset that, oh yes, dad went to work on the construction site and there it spread again. But I think looking at the culture and the structural issues give some context to what was happening.
I want to hear from A, and then I want to give you my what I would do if I were the prescribing physician here.
So, I have issues with the culture of science deniers. I was wondering if Rebecca could comment on the structure behind science denial or lack of belief in medicine and modern day technology. I'm not really sure how to deal with these folks. I mean, I understand that not everybody has the level of education that we do, but it doesn't necessarily require this level of education to accept the benefits of modern technology in our modern life, and to just reject the vaccine or other things that we have available, masking. It did, despite the science demonstrating its benefit, it just doesn't make any sense to me.
I'm going to let Emily go, and then I'll respond. Go ahead, Emily.
Okay.
Great. So no, I do want to hear Rebecca's thoughts on this. When I think about Manshada's writing a prescription that the patient join a tenants union, and the parallel for me in this case is I would write the prescription for ending the political duopoly in the United States of Republicans and Democrats and their deregulation of media since the gutting of the 1933 Fairness Act, which required media outlets to portray multiple perspectives on the same topic. And I'm only this much facetious. I really believe that that it's incumbent on those of us who are voters and politically engaged to recognize that we have allowed Democrats and Republicans to perpetuate a capitalist media landscape that disinforms. And there's not a good way to address that at an individual level. And if we don't re-regulate what it means to be news or media, if we don't break up conglomerations of media giants, we will not have a systemic way to address not just vax deniers, but a lot of the ills that we're facing. Rebecca.
Yeah, I agree with that. I also think that we have models of capitalist kind of welfare states, and especially in Scandinavia, that operate from a kind of hyper individualism, but it's also collectivist mentality. And I think that if we can do anything in this society, it would be to think, as we talked about at the beginning of this whole thing, of how to foster social fabrics that cultivate a collectivist mentality. And, I think we're so used to, when I look at people like my aunts who, post on Facebook regularly about this, they're like, my body, my choice, right? They're embracing some of the same logics that we've used for, what we might call leftist political projects historically, but they're all rooted in a kind of individual choice model. And I think that our economic system, I think our political system, I think our social system all leads to that. And so we need to do better in this country. And these are all kinds of policy issues. There's just, I think it's so overwhelming. I don't actually, I actually am fairly sympathetic to anti-vaxxers. My kids are vaccinated, as am I. I got the booster or whatever, but I'm fairly sympathetic from a scientific perspective, even though they are killing people, that they're also structurally caught up in a kind of maelstrom that's political and economic and social. And so I don't think that more information is actually going to help them. I think actually trust, rebuilding social fabric, allowing for a diversity of opinions. I think those are our best routes out. Changing the structures along those lines, I think, would be helpful. But, yeah, the consequences are life and death in that regard, but so are lots of other things like going to war or other things. So, I don't know. I don't know that we're going to get out of it with better science. I think we need to get out of it with better social policies and more understanding, which is, I think, ultimately what I'm trying to get at with a structural perspective, is that we see where people are coming from and don't treat them like they're stupid. And this is where Emily and I kind of meet in our like cultural and structural foci, and then try to build trust and move forward together collectively. That's going to be really hard. I don't know how, I don't have a really good solution for that, but I think that's what we need.
And we'll stop on that note. Thanks for letting us go a few minutes over. Sorry to impinge on your time.
No, it's fantastic. I'm going to have a lot to think about the rest of the afternoon and probably in the days to come. So thank you so much for providing your time and this amazing presentation. We really appreciate it. Hope you all
Can I just say one more thing, Sarah?
Yeah.
For our PowerPoint are a couple of readings. I've also included my cranky article against competence, but also 3 readings about structural competency. So just if you all want some further reading, there's that. And if you want to have other readings beyond this, you want other recommendations, Emily and I will be very happy to provide those to you as well, or for your learners as well. And we'd be happy to come talk to your learners if you're interested.
Perfect. Thank you so much. And as always, I'll make sure that all of this is available to you all up on the website. And I'll see if I can pull these articles for you too and put them in your reading folder for this session. So we'll make that happen. Well, thank you, Dr. Hester, Dr. Satterwhite. I look forward to talking with you all soon. I think I owe you lunch when things clear and I can get up to Blacksburg at some point. So thank you.
So great to meet
everybody.
Thank you so much.
Yeah.
Thank you.
Absolutely. All right, everyone. So we'll break until 12:30. Do feel free to bring your lunch back with you. You might not have enough time to finish all that. So feel free to bring it back and we can have a working session lunch when we come back and hear from Dr. Morrow. So I will see you in just a little bit. If you have questions or need anything, I'll be here. So just hit me up in the chat.